All right. Hello, everyone. Thank you for joining us. I'm Sandro Tejada, Director of Major Gifts and the Seton Hall Parents Program. Again, thank you for joining us during Seton Hall Week in our virtual offering, Back to School with Dr. Robert Scoleveno, Clinical Associate Professor and Director of Clinical Simulation at the College of Nursing. I just want to let you know that this session is being recorded. We will have an on demand page and we'll add all our Seton Hall Week recorded sessions to the page. Please kindly mute yourself, and if you have any questions during this session, please use the raise your hand icon on the top right of your screen. You could also use the chat feature to share your questions or hold your questions until our Q&A session. As you probably know by now, Seton Hall Weekend is Seton Hall Week this year. While this year's event will look much different than it has in past years, we are committed to provide a week-long experience full of engaging virtual offerings for our families, alumni, students, and the community. I have the great honor to now introduce Dr. Scoloveno. Thank you, Doctor.
Yes, hi. Thank you very much for attending this. I'm trying to get my PowerPoint slides back up so that you can see them. Hopefully you can see that.
Yes,
I
we can.
appreciate the time, Sandro. Thank you very much. My name is Bob Scoloveno. I'm the Director of Simulation and I'm a Clinical Associate Professor at the College of Nursing at Seton Hall. Basically what I do is run the simulation component of the students' learning experience. At Seton Hall, we're blessed to have a state-of-the-art facility on our new, relatively new IHS campus, which opened in 2018. So our goals today is to kind of give you an understanding of what simulation is and how we use it in nursing, and also interprofessional education. COVID is among us. I know everyone has a deep understanding of this, and it forced us to really be creative in how we make sure that the students' learning objectives are met. I'm happy to say that we really are meeting the students' learning objectives, and I'm very, proud of the work that we've done so far on the campus to make sure that the students are not only safe, but making sure that they get the information that they need to be successful nurses. We're going to also identify our potential advantages and disadvantages of simulation as a teaching strategy over actual clinical experiences that the students may have out in the field. And at the end, you'll see a virtual tour of some of our laboratory space, which, as I said, and Sandro said, we are lucky to have it, and it is a state-of-the-art facility. So we're located in Nutley. So we're about 20 minutes off of Seton Hall proper in South Orange, and it's a wonderful building for the students. It houses 3 schools, one of which is the College of Nursing. We also share the space with the School of Health and Medical Science and the relatively new Hackensack School of Medicine. So, what is simulation? Simulation has been done in other disciplines since the beginning of technology. But what it really does is bridge theory and real life clinical experience. It has 4 main components. We have an education component, an ability to allow our students to be tested so we can assess their progress. It allows us for research, especially in areas of education where we can kind of improve our methods of education. And it allows us to use a health system integration for patient safety. In my background, I've been doing simulation for probably about 20 years, but my research focus is in resilience and educational outcomes of simulation, and patient safety is a large component of that. I was a fellow at the VA in Philadelphia for 2 years, and there I really was able to develop a deep understanding of how important it is not only do we educate our healthcare practitioners, in this case nurses, but make sure that they're able to effectively function in our hospital systems, in our healthcare system in the United States. So safety is a large aspect of that. So why do we do it? Well, provides us an opportunity to learn, practice, and make mistakes in a safe environment. Students are constantly asked to do things in the hospital setting, in the clinical setting, that sometimes they're not comfortable doing, and certainly the patient isn't comfortable having them done by a nursing student, and our community partners are certainly not very comfortable in having novice nursing students do some of these aspects of healthcare. So we give them a safe place to where that they did make a mistake. The stakes are not very high in that we're using simulators. We want to develop confidence in our students, and we want to be able to make them have safe care and effective teamwork. Team building goes along with patient safety, and this also has an interdisciplinary aspect that we focus on at the IHS campus. Clinical decision making and clinical judgment are two really hot ticket terms now in nursing education, and we are really trying to develop what we call clinical reasoning and decision making abilities in our new nurses. Simulation, they get to watch themselves back, and it gives them insight into the actions that they do, and there's positive and negative feedback, and they have the ability to self-evaluate. And since we are sharing the space with two other schools, interprofessional planning and experiential learning is really what we're able to do in the simulation environment. So when students are transitioning from students to RNs, they say that they're fearful, they're not confident, they have communication deficits, they're not sure about their complex decision making, they're just sometimes afraid, I guess is the best word, and it takes them time. As nurses, we're a professional school, so our students are licensed to go and practice as nurses, but it takes them time to get comfortable in their abilities. Simulation helps us bridge that gap, make it a quicker transition and a more confident transition for our students to go out into practice, which leads to them staying in the profession, which is ultimately our goal. So we use simulation as a teaching strategy and an evaluation tool. Two things. It is a part of the curriculum. It's not just something that they do. It has to integrate into the lexicon of what our culture is at the school. And I will say at Seton Hall, as being relatively new, I've been there about 2 years now, and the simulation program, the faculty are incredibly receptive, and the administration is incredibly supportive of these initiatives. So again, in trying to bridge that gap, what are our graduates saying? Well, they feel uncomfortable with certain skills. Okay, and it doesn't always have to be caring for sick people. It could be caring for well people as well. But some of the aspects of what we're trying to accomplish is give them an broad approach, so that when they do go out into practice, they will have a really good handle on some of the things that they may see on their own as practicing nurses. Our practice partners are saying that nursing students, when they kind of come out, fail to perform relevant nursing actions. They're, as I said, this theme of the fearful interaction. They're having a little trouble prioritizing. They're not always complete information to the healthcare provider, and sometimes they're doing nursing actions, and they're trying to having a hard time coming up with the rationale. And this is our graduate students, and the students at Seton Hall, they get a very rigorous curriculum and have a wonderful reputation when they're out in practice. This is this slide here is not specific to Seton Hall. This is a challenge for nursing schools all over the country to kind of get students out into practice at a ability where our practice partners are also comfortable. That's where simulation comes in. Now, there's two different things here. A simulator is the device that we will use to kind of give the student the experience. Simulation is a application of the technology. It is not technology. So most professional schools, really at any level, doesn't just have to be in healthcare, are using simulation as some aspect of their curriculum. So, where are we heading in healthcare education? Well, we need to provide more experiential learning opportunity than instruction. We have to bridge the gap to where our students are and where they can be based on our practice partners and what is important out there. As I said earlier, patient safety is a large component and a huge challenge that we have in the United States healthcare system. We want to increase the use of learning technology, and we're trying to say that we want to be outcome based and not process based. We want the students to understand what is the outcomes for them and what is their goals or the outcomes for the patients. And then evidence-based education is now has firmly taken hold in nursing education, and this becomes very important because it makes faculty and challenges faculty to make sure that we teach to the highest level of evidence and research and literature that's out there, rather than taking "I'm going to teach you how I was taught" approach. So, what's our rationale for simulation? To kind of recap, we're trying to prepare and promote new nurses. We want them out there ready to go, comfortable. We want them staying in the profession. Overreaching percentage of high percentage of students that graduate from undergraduate nursing programs enter into practice right away. There are some that go on to graduate school, and we encourage that. But for the majority of the students, they want to get out and practice. Now, we're doesn't only mean that they'll be practicing in the hospital, but certainly that's where many of them wind up. So our goal is to make sure that they're not only have the theoretical knowledge to excel, but the practical knowledge as well. Simulation allows for innovative and new teaching strategies, and we want to support that. And our clinical sites are challenged with the increasing number of students and the decreasing number of clinical sites. There are shortages in faculty and preceptor availability, and we kind of try to use simulation to overcome some of that. The students are exposed to all types of simulators in their time at Seton Hall, and it starts right when they start in their first lab class as a sophomore. Low fidelity or task trainers are things like blood pressure arms or little injector pads where they'll learn how to do injections and draw up medication. Medium fidelity or become like a real life size mannequin, but they may not respond at all. They just may be what we call a static mannequin, but it gives them an idea of the anatomy in terms of how they're doing things. And then our highest fidelity mannequins, they physiologically are responsive to our students and act very much like a real person would out in the real world, and that's how we try to portray it. The students are oriented to the simulation lab very early on as part of their first health assessment course. That way, as the simulations get more and more intense, the students are more and more comfortable with their lab and the surroundings. Aviation is an example of people that have been doing simulation since the beginning of flight. Anybody that's seen any movie about space or the space program knows that NASA relies heavily on simulation to educate and train their astronauts. We're just trying to build on that in nursing education and healthcare education. We're not under the impression that we invented simulation in any way. What we are trying to do is utilize it as a relatively new form of a method of education for our students to give them the best possible learning experience. So what can it do overall? It more or less is it's a jolt. To me it's a jolt to the students' curriculum. It forces them to promote teamwork and collaboration. They have to practice safely and effectively. It allows them to delegate. Um, Cultural awareness. It makes them understand what evidence-based practice is, and of course allows for patient-centered care, which is another big term that you may hear now in the healthcare setting. Basically, what we do with simulation is take some of the perceived weaknesses of the students, which will naturally happen due to the nature of the profession, and we try to get them to a point where they are much more comfortable entering into practice. Hospitals are not orienting students as much and as long as they used to. It's very expensive. So again, we're just trying to bridge that gap. These are just some more advantages. I think one of the biggest things for simulation is it allows for immediate feedback. We tape all of our sessions for the students. They sign a waiver. We sign a confidentiality agreement. Students are really not graded in simulation to the aspect of that they're going to get an A, a B, a C, or a D. They're just more or less evaluated based on their readiness, or their how comfortable and how confident they are. And we have them fill out surveys. So after they do the simulations, there's a debriefing aspect, which I'll touch on briefly. So any clinical setting can be realistically simulated. We provide a hands-on experience, and we give them rare events and high-risk patient situations. These are the things that the students crave. They want to be able to take care of the patient that's in a rapidly changing situation. It's not always what the focus of our education is on. You know, not every patient the students will come into contact with will have a rapidly changing situation. However, since the students seem to really feel like this is what will help them along, the evidence does say that to kind of get them ready to move out there, giving them some really dynamic cases helps them with their confidence. In the clinical setting, even in the most acute care clinical setting, the students will not be able to participate in, let's say, a code blue situation where the patient has now moved into cardiac arrest. They could certainly observe it, and there is a lot of evidence that says observing is equally as important at times. But most of the time they'll report, well, we were able to observe this, but we really want to know how would I perform in it. So we can realistically simulate pretty much any situation that they see in the hospital setting, or the community setting, or the school setting, wherever we want our setting to be. We're also going to guarantee them exposure to certain clinical experiences. We know that out in the field, not every student is going to have the same exact experience. They're at different settings. There's different patient populations. They're certainly there as a group. So in simulation, we shorten it. We make our groups much smaller, and now we can say all of our students in a cohort, say the junior level students, get consistent and comparable experiences. And our students come into the simulation lab in every clinical course that they take, starting with the health assessment and fundamentals course, going into the adult 1 course, and finally finishing with their synthesis course. So they're basically coming to us over a 3-year period, more, sometimes twice or 3 times in a semester, depending on the course. So we want to engage our students in active learning. Active learning is the key. We cannot afford to have passive learners. And of course, anybody that works in education will tell you that sometimes there are passive learners. This allows us to assign our students, which we feel may be trying to stay in the background for whatever reason, and we can push them up to the forefront. And we can establish benchmarks for performance. We want them to have an understanding of what is expected of them, and we certainly can say, and the literature will say, that whatever they learn as an active learner will potentially transfer to care of their patients once they're licensed. Mistakes happen. Medical errors in the United States, there are some literature that tell you that sometimes 4 and 5 encounters with a patient, there's some form a medical error that occurs. Biggest type of medical errors is medication distribution. Mistakes happen in the real world and mistakes happen in our simulation lab, and we encourage them in terms of saying to the students, do not worry about it. You made this mistake. Let's address why it was made. Let's correct it, and let's try to move on as if it didn't happen for the next time. Knowing full well that it is a difficult proposition in our healthcare system in the United States. Rapidly changing situations sometimes do occur in a medical era, unfortunately. We're trying again to bridge that gap. The debriefing session allows students to reflect, assess themselves kind of right away. They can view it, and there's really no practical way to do this in the clinical setting. There's no way to record yourselves, and it's more or less you're coming back from memory, and sometimes the students don't remember things that have happened as readily as if they were watching themselves on the screen. So, what else can we simulate? Communication can be simulated. Teamwork can be simulated. Delegation can be simulated. Pretty much everything that can be done out in the setting can be simulated. And our students now, as you know, are technologically savvy, and this appeals to them. They like the idea of using the technology to help them learn. We have digital natives. It's much more difficult to teach the faculty how to use this machinery, technology, for lack of a better term, than it is for the students to be comfortable in it. So, infusing simulation into nursing curriculum can be a daunting task. We need to get faculty buy-in and adopt simulation. It takes time to learn and develop this technology. It's very expensive technology. There's also no time available to create and develop new scenarios. So we have to every couple of years have in-services because we're always trying to upgrade and improve our scenarios. And also as the faculty sort of develop this stuff and learn the technology, you're really not compensating them for that. They're coming in on their own time. We have some ways to help mitigate some of that. We have simulation specialists that are assigned to the lab. They're in charge really of the technology and the upgrading technology and troubleshooting. But we do need to have the faculty as part of this because faculty are in charge of the curriculum. We want to make sure that the simulation activities are meeting the curricular needs of the program and the course objectives for the students. So this slide kind of tells you when we're trying to change things, and simulation is a change. Now I've been doing simulation for 20 years, so I will say that the resistance is very not the same as it was 20 years ago, but there is a certain barriers that you always have to overcome when you're integrating new things. One of them is that we've always done it this way, and we were taught a certain way, so why should we change? Again, this gives you an overall idea of the challenges that we have when integrating simulation, but I would say that I was remarkably impressed with the way the faculty at Seton Hall accept and embrace simulation as a necessary component for the students' education. So, human patient simulation is kind of where we're at now. We have the highest fidelity mannequins that are available, and I'll show you them in just a couple minutes. We have interactive experiences. We can animate their theoretical knowledge within the context of the clinical reality. The way we have our simulation set up is the students will get the theoretical component of what they're going to do in the simulation lab before they come into the simulation lab. For example, if they were going to do a patient that was going to have chest pain, they would have already had the cardiac component of that piece of their course. So that when they come in, they're sort of putting together the theory with the clinical, and it merges together quite synergistically, which is what our goal is. Simulation, when you're using the highest fidelity mannequins, immediately helps them with their critical thinking, decision making, and delegation. And we want the students to get to the highest level of learning possible before they're able to get out into the field and practice. There are some limitations. It is costly. The mannequins, there's a couple mannequins, and I'll show you them in, like I said, just a few minutes. They're upwards of $85 to $100,000. We have to pay to have them maintained because we do use them quite effectively and quite a bit. So we also have to limit access. We can't have them running 24 hours a day, and we certainly can't have the students in there on their own with them. And we have to make sure that the people that understand and really know how to run them are available, and people are not always available. So we have to schedule it out very strategically. And also, there are some limitations in the realistic human interactions when you're doing the highest fidelity mannequins. That's why in our undergraduate experience, we use standardized patients, which are actors that are trained to portray an illness, and that helps us get to that higher level of real interaction. Dale's cone of experience and learning will tell you that there are certain ways that you can learn, and you could read here and go on the list. So what we're trying to do is make sure that we don't have passive learning, we have active learning. And active learning is people are going to recall 90% of what they do. So we want students in the lab as much as possible, hands-on, really practicing their profession. And that takes time, it takes resources, and it certainly takes money to be able to do that effectively. So, what are some potentials of simulation over actual clinical experience? Well, some of these we've already gone over. One of the big things on this slide is we can schedule it and we can reproduce it. Every student that comes in gets the same exact scenario and the same exact experience. That doesn't mean that the scenario goes exactly the same way, which is the great thing about it. It's almost like watching a Broadway show play out live. You'll see two student groups come in and they'll take the scenario in two completely different ways. And all of that is positive because they're going to get debriefed and they're going to have feedback to that. To integrate simulation, we're talking about changing our curriculum. We want to make sure we go from the simple to the complex. We want to make sure the students are exposed to it early. We want to make sure that we're using it for remediation and clinical makeup. The more that they're involved with the mannequin, the more and the simulation lab, the more they demand it, and that helps us out in the long run. The important components to a simulation is the students are made to prepare. They know the objectives. The objectives are developed with the clinical faculty and the theoretical faculty. They have to actually take part in the simulation. They have to debrief, and then they have to evaluate themselves, the simulation, and each other and their peers. That's a component to an overreaching simulation activity. Our challenges as faculty are how do we marry this content into the curriculum, and how do we reiterate it in simulation. We're also reframing content that we're teaching in labs and didactic, and how do we reframe that to fit within the simulation theoretical learning environment. Debrief, as I said, allows the students to reflect. We videotape everything. I'm going to show you in just 1 second a brief video of what it looks like in our lab, and you'll know that these are fundamental students that have not been out into the hospital yet, so they're just this is like one of their very first times that they're going to be coming in, and they'll be helping a patient that just had a hip fracture. one of our goals of debriefing, it's really one of the most beneficial parts of simulation when it's done correctly. And our faculty do it wonderfully. The students are supposed to guide it. They're supposed to talk about their feelings, the team's performance, their own performance, what they would do the same, what they would do differently, and it encourages collaboration and communication. And as they sort of hear themselves talk, they start to think right in real time, well, if I was given this again, I would probably approach it a different way. And sometimes we'll bring them right back into the lab and let them play that out. They always debrief as a group, and there's always observers. They always focus on critical thinking and specific learning objectives. And the faculty is not there to evaluate them, but to facilitate the conversation. It's very, very important to the simulation program. Without the debriefing, the students would actually report less confidence and less satisfaction. It would be because we're putting them in situations that they're really are not trained for yet. I mean, we're expecting them to act as nurses in the simulation lab, and they do quite well, but they certainly aren't going to do it as if they were a seasoned nurse. Learners have the opportunity to explore and deal with feelings and that they experience during simulation. Will be better prepared to deal with them in their real clinical situations. That's really much the goal. And as they respond, that's going to guide the discussion of the events. So no two simulations are the same, no two scenarios are the same, and no two debriefings are the same. Yet it's all standardized, which is wonderful. So this is simulation in action. Basically, this is our maternity room. This patient is a female mannequin, and she is, I'm going to show you just briefly, she is had a hip fracture. The student that is sitting there is acting as a patient's family member. The two students at the bedside are acting as nurses, and the other student that's joining now is acting as a nursing assistant. And they're going to log roll this patient, put them on the pan to help them go to the bathroom. Okay, so basically what that tells you, I'll actually go back to it. Basically, what you see there is, and I'll show you the next step is our tour, and then I'll ask you your questions. That room is set up as a intensive care environment. It's quite realistic. We're proud of it. These students here are, this was taken last year, so they would be juniors now. And they would have debriefed this scenario, they would have talked about it, and it stays in their kind of catalog, and they could also go back and view it at any time. And we use that to show the students their growth. So our simulation tour, just to kind of give you an idea of what we have on campus. I'll go through this quickly so we have a couple minutes for questions. Our building is split up into wings or suites. So the first thing I'm going to show you is our 2500 pod or our 2500 wing or our 2500 suite, however you want to say it. We have a nurses station that is available to our students, and that is outside the rooms. And if you see hanging there are microphones, you can hear what goes on, and we can also talk out into there. The nursing station features 3 computers for multiple students. It has overhead cameras, microphones for recording. There's 2 monitors, which we could put all the simulators their telemetry right onto those monitors. This is we have 7 of these rooms. This is a high fidelity simulation room. This one is set up like an intensive care unit room. It could be an emergency room. It could be a regular patient room, however we want to set it up as. The mannequin you see there is called SimMan 3G. He's pretty much the highest fidelity mannequin you could have. He'll talk. His arms will articulate. You could hook up the IVs. You could do CPR on him. The students will get all realistic sounds, and he talks. We either talk for him, or he has the ability to talk on his own with the pre-programmed script. We have 4 med-surg rooms. So of the 7, 4 of them are med-surg rooms. There's also an operating room and a pediatrics and a maternity room. They have walls which kind of open and close, and our tech team will do that based on the needs of the patient. These are also very large rooms, so we could fit multiple beds in here. And we also use these rooms for our standardized patients to interact with students. Our pediatric suite. What you're seeing there is Sim Junior, they call him, and over on the right is Sim Baby. He's set up just as a general pediatric ward. If you look all the way to the right, that's our observation room. You see the one-way mirror there. We can see out into the room. The nurses and students can't see us. And that helps with observing. But like I said, also every room is recorded and audio capability. Pediatric unit has Sim Baby. It's capable of chest rise and fall. Cyanosis is a state-of-the-art baby. The students love playing with him, and because that's really they report they're sometimes it's hard for them out in reality to take care of the baby that's crying. This is Sim Mom. She would have just had a baby, and to the right over there is Sim Newbie in our bassinet. The Sim Mom, we have 2 of these mannequins. They're the only female analog high fidelity mannequin available, and we're lucky to have. And she could have a baby, and she could also have other issues that are unique to the female population. And our 2400 wing is where we do most of our standardized patient work. And here we have 16 exam rooms that are set up just like your regular doctor's office. And it's designed for encounters with professional actors or peer-to-peer. We have a recording system throughout the whole building. It's called Beeline, is the company that manages it. And you can record, assess each individual encounter. And every room has their own computer, so the students actually do their documentation in real time, much like when you go to the physician's office now. This is a control room. This is one of them. This is a centralized control room that controls the whole 2400 suite. We could see every room in the building that has recording capability from this room, or you could also see them from the individual rooms in the 2500 pod. 2400 pod, the only way to see into the rooms is to use the control area. This kind of gives you an idea of the view. You can see all the hallways, the nurses station, any room that's available. So I do appreciate your time, and I know we have a couple minutes left for questions if anybody has them. I know some areas I touched on quite quickly, but I want to make sure you got a really good overview of our capabilities over here at Seton Hall. So if there are any questions, please let me know.
There's one question from Rita Salva on the chat. It says, you listed teaching cultural awareness with simulation. Will you please explain how this is done?
Okay, so we have mannequins that are So our newest mannequin is a nursing and simulator. So she is based on a 16-year-old African-American female. So we use the diversity of our mannequins to kind of show the diversity of the population. When we talk about cultural awareness, the students have a course in cultural foundations, and pretty much what we do is integrate into the scenario whatever we want to address, whether it's the homeless population, whether it's a culture of Pacific Islander, or Native American, or even people from Asia. There's certain cultural, unique cultural aspects of their care that we want to make sure the students have an understanding of. So not everybody is approached with the same broad brush. So we make sure that we integrate a lot of that into our simulations. I hope that answers.
We have one more question on the chat. What year do you begin your simulations at the IHS campus?
So the students it follows the curriculum of the College of Nursing. So the students will come starting in the sophomore year with their first class would be health assessment, where they'll kind of learn how to take blood pressures and vital signs, and certainly there's more to it than that, but they'll come the fall semester of the sophomore year, and then they'll follow each semester from there on until they graduate. They'll come to the simulation lab. Well, to the IHS campus is where their classes are from there on, but they'll certainly come to the simulation lab at least 2 or 3 times in a semester.
Great. We have another question. Are there any screen-based simulation or tablet sims?
So yeah, so we actually use, especially now in our time of mitigation with COVID, we're not actually able to have as much traffic through the building as we normally would, because we just don't have the time. So we actually are using a product right now called vSim. It's a product from Wolters Kluwer or Lippincott. And what that is a very real analog and simulation in terms of the question. The students have a pre-test, a post-test. They have a actual scenario. They prepare for it the same as if they were going out to the clinical site or to the simulation. And they actually have to go through the scenario in real time, asking the appropriate questions and making the appropriate decisions. They'll get a grade on it. They have a chance to continue to do it until they get the grade that they want. But one of the that's a major product using right now. It's called vSim, and that's they do it right on their computer at their house or wherever they are, and then the faculty will debrief with them on Teams. That's what we set up. We also have the ability to take all of our scenarios are developed through partnership with the National League of Nursing. And we're able to take those scenarios, put them into the software that run the mannequins, but we could also extrapolate those scenarios into a what we would call a case study, because it's not as interactive, because the students won't be able to make decisions that will change things, but certainly will allow them to see potential changes in the patient. So that software is called LEAP, LLEAP. So those are the 2 main methods of what I say virtual simulation or 2-dimensional or tablet computer-based simulation that we're using.
Okay, we have a question from Tara Hart.
Yeah, I saw her hand up.
Actually, one is a comment and then a question. The comment is that I have a niece who's a student in the Seton Hall nursing program, and she was super excited when she successfully did her first in a clinical rotation IV, and she had shared with me like it's so much easier because of what I do in the simulation lab. So thank you for what you're doing to help it be easier for her as a student nurse. And it made me reflect as you were showing the mother baby unit. When I was having a C-section, there was a student nurse not from Seton Hall's program, from another local college, and I could basically tell over the scrim by the end of my baby being delivered she was going back to school and changing her degree. So I'm wondering if there's any information or data on, does this higher level simulation help with greater levels of retention, or alternatively, with helping a student decide this isn't the field for him or her, just on simulation before going into a clinical environment?
Right. So that's a really good question. So I could take that on two levels. From a nursing student perspective, it helps them reinforce their want to be in nursing. We haven't had students, our attrition rate at Seton Hall is very low. There are not many students that decide, let's say at the junior level, that nursing is not for them. Most of the time it happens before they get to us. Now, so I think simulation helps kind of make it a little bit more palatable for them to go out into the field, because they're given a certain expectations, and they also go out in groups, so they have support system within themselves. What we need to do now is follow our graduate students. Now that simulation is so much part of our lexicon, we have to follow them out into practice. And I would like to know if level of simulation that they're exposed to in their schooling help keep them in the profession. There is a 3-year burnout / attrition rate that nursing is dealing with, that we have been dealing with for many, many years. Unfortunately, now with the COVID-19 being among us, for certainly a greater part of a year, it's going to kind of alter the landscape for the next few years. But as far as a nursing student perspective, in my experience, and this is over 20 years at different institutions, the simulation component of their education helps reinforce them and make them more comfortable and confident in their decision to become nurses.
Thank you.
You're welcome.
We have one more question on the chat. Do we have time for, I think somebody raised their hand and we have one on the chat.
Okay.
We good with time?
Yeah, that's fine with me.
Okay, from the chat, have you seen a correlation between the addition of more advanced simulation in the new facility to better student outcomes?
Oh yeah, definitely. Having the ability to do it at state of the art. I can't say that if you're doing it, when we were in South Orange, it was one space. I can't really say that it's the space that does it, but what happens is, because we have so much more space, we can more comfortably schedule them in for more scenarios. And there's also the interdisciplinary aspect of it, which SHIMS kind of already has their core interdisciplinary education that our students are now taking part of. And we've also done some interdisciplinary situations where students are interacting with physician assistants or medical students or occupational health students, occupational therapy students. So the outcomes in terms of simulation have really been off the chart. Their confidence level is soaring. What we want to do is really kind of coordinate that with the theoretical objectives and make sure that we're meeting them. But I will say that our NCLEX pass rates, since we've been on IHS, they're at 94, 95% now. And I'd like to think that simulation has played some part in that, and I think it has.
Great, and then we have one question from Joe. He has his hand raised.
Hello, can you hear me, Dr. Scoleveno?
Yes, I can, Joe. How are you?
Very good. Hi, how are you? I'm Joe Lopriato, the Associate Dean for Simulation Education at the Uniformed Services University, and a proud Seton Hall graduate from the class of 1977. So I'm coming to you today from Washington, D.C. Just wanted to say congratulate you on your new center. You will give me a tour sometime, right?
Oh, definitely.
And
yeah.
The question I want to ask, and again, I know you're very proud of your students and your facility, is what's your vision for your center over the next 5 years?
So my vision for the center over the next 5 years is to be a interdisciplinary tent pole in the Northeast region of the United States. Patient safety and interdisciplinary education are two passionate areas for me that we really need to address. And the reason why I stay in simulation, my research is in resilience, which had nothing to do with simulation. It was resilience in middle adolescence. But the reason why I stay in simulation is I have a large amount of skin in the game in terms of what I want to see our country look like and how we address patient safety and how our healthcare system works better together. Since we are, and one of the things that drew me to Seton Hall is on the IHS campus, we have medical students, health sciences majors, whether it's physical therapy, occupational therapy, physician assistant, athletic trainers, and of course our nursing students across graduate and undergraduate levels, all sharing the same space. So my 5-year plan is to have a true interdisciplinary simulation education center.
Thank you. Excellent goal. You know, you always have a friend here at the Uniformed Services University.
No, I really appreciate that, and I will certainly reach out. I'm finding out quickly how loyal and helpful the Seton Hall family is in terms of alumni and people that are here. So I really appreciate that very much. Thank you.
You're welcome. Good luck.
Thank you very much for the time, and I appreciate the platform to kind of show us a little bit about what we do. If there's any questions whatsoever, please feel free to reach out to me, and I'll answer them the best that I can.